Now it's coming probably. Respected chairpersons and very, very learned audience. Assalamu alaikum. Actually, this IPD stage is today very much blessed because we have a series of gigantic speakers among us. And with some exception also, I'm Dr. Ishtiaque, and I'll be discussing about the importance of recognizing congenital aortic anomalies. I work in the Department of Pediatric Cardiac Surgery at National Heart Foundation and Research Institute. As all of you know that we are actually born with a number of aortic arches, which ultimately, with a systemic regression and remodeling, become only one. It does have three branches, as we all know about it. And we call it a left aortic arch because it arches over the left principal bronchus. But there are situations when the systemic regression and remodeling doesn't occur, and there is abnormal persistence and abnormal involution, giving rise to aortic arch anomalies. Well, when there is a deviation from the normal arch, of course, it looks different than the usual that we used to see. In one of our patients also having this sort of aortic arches, looking like almost a rail of the roller coaster. It doesn't create really much problem as long as it doesn't create a circular, which encloses the trachea and esophagus, and which is known as the vascular ring, and constrict it is this aerodigestic tube. Sometimes this ring is not complete. We call it an incomplete vascular ring. And there are times there is no vascular ring, but the origin and also the course of these vessels are so that it, giving compression to this trachea and esophagus, we call it non-ring compressions. And of course, there are a situation we know about this. There is a sling formation of the vascular ring, which also causes compression of this trachea or esophagus. And of course, for planning about any surgery, when we are dealing with the aortic arch and also doing a cath procedure, mostly through the radial artery, we must know the anatomy of the aortic arches. There are different type of aortic arch classification listed in the textbook, but what I felt very easy for me to remember and understand is the abnormal branching, abnormal arch position, supranumeral arches, and others. Abnormal branchings are the normal variants of the aortic arches and abnormal left aortic arches. Among normal variants, there is two arch vessels coming out, which is a bovine aortic arch or a four arch vessels coming out of it. In abnormal left aortic arch, there is a retroesophageal right subclavian artery, which often giving compression to the esophagus. That's why known as the arteria luceria. And also, sometimes there is a diverticulum present at the origin of it, which is known as the diverticulum of Comberell, which does create a vascular ring, but more importantly, it has a tendency to dilate and give rise to thoracic aortic aneurysm. In abnormal arch positions, we can classify as aortic arch, cervical arch, and circumflex arches. Among the right aortic arch, this is it arches over the right principal bronchus, and it is evident through the X-ray only. And there are different varieties of it. I am not going in detail of it. Cervical aortic arch comes next, which is where the arch is there in the thoracic inlet, giving a pulsatile mass over there. And the circumflex aorta is there, which the arch has an atypical form and shape and turns and around the trachea. And regarding the supernumerary arches are maybe double aortic arches when both the aortic arch remains, doesn't get, and also persistent fifth aortic arch, which is creating a double barrel type of aortic arch. And in others, in fact, there is interrupted aortic arch, anomalous origin of the right pulmonary artery, isolated right arch vessels, as we can see over here, and of course, vascular ring. Well, if we can summarize the list, in fact, it comes like this. The red ones are the vascular ring formations, and the yellow ones are the non-ring compression reasons. Well, the patients are usually asymptomatic, but they can have life-threatening respiratory failure and intractable feeding intolerances. Mostly those who are having an anterior non-ring compression do have a respiratory issue, and for the patients who are having a non-ring compression of the from the posterior side have a dysphagia and other GI-related issues. And for vascularists, in fact, both type of symptoms can persist together. And the treatment option is then for suspicious cases, we can go for an echocardiography, which almost gives us the diagnosis of most of the arch anomalies. CTA gives a good uh, definitive diagnosis as well as detailed information about the arch and its anomalies. Bronchoscopy is a good choice after that. For the double aortic arch vessels and vascular rings, aortic surgical repair is the choice. For the patients who are having a symptomatic or airway luminal reduction more than 50%, should go for surgical repair. For the asymptomatic patients or who are having a concomitant CT surgery, surgical repair is reasonable. And for the patients who are having asymptomatic airway and their airway reduction is not much, we can go for a regular follow-up for this patient. But now cut to the chase. In fact, if I am asked that how many babies are born with vascular in Bangladesh each year, for sure we don't know it, in fact. But statistically, if you calculate it, comes around 25 to 50 babies are born. And if I ask the question, how many babies are get operated each year for vascular ring, I guess maybe it is 1 to 5. And if I make the question more specifically, that how many babies get operated each year for isolated vascular ring, no associated cardiac anomaly, probably I cannot start counting. The question is why? Two possibilities. One is the incidence of arch anomaly is less than usual in Bangladesh. Another, we fail to diagnose them properly. Well, if you consider the first one, and if we look at the arch anomalies that we have encountered our National Heart Foundation and Research Institute for last couple of years, we can see that almost the entire list we have touched. And those were diagnosed during the evaluation of cardiac anomaly. So probably the first possibility is not true. So there is chance that we fail to diagnose them properly. There's true reason behind it because these patients usually come with a lot of respiratory issues and GI issues. Hardly they have some cardiac issues. As a result of which, the heart anomaly is a real stranger in the list of the differential diagnosis of these problems. That's why the patients often present with prolonged histories of respiratory and gastrointestinal symptoms that have been misdiagnosed for months, even years. So there are promising avenues to improve. Of course, we can enhance our screening techniques by giving focus on standardizing the prenatal scanning as well as improving our echocardiography protocols. And also, we can utilize and advance imaging technologies like MDC, CTA, or MRI. And of course, the first one that we should give more emphasis at growing awareness between the pediatrician, the pulmonologist, the ENT specialist, cardiologist, and of course the cardiac surgeons. We have to know and we have to remember that there is no alternative of high level of suspicion to diagnose aortic arch anomalies, a treatable disease with excellent outcome. So don't miss the aortic arch. Thank you so much. Before ending, actually, I have a small message for our residents and trainees who are here. The images that I have used here are drawn in 3D. So probably this talk will be there in the IPD website, so you can download them. And for me, actually, when I first read all those aortic arch anomalies, it was really difficult for me to imagine these 3D orientations. So hopefully this will give some help for you. Thank you so much.
Thanks, Dr. Ishtiaque Manzo, with your brilliant presentation.